record. Okay, great. Okay, well, hi again, everyone. So excited to have Carly and Nika with us today talking about out of control sexual behavior. I met Nika kind of recently, and we just had a really sweet connection and a wonderful time over a shared meal and learning about her work. I was really inspired by just the compassionate, non-pathologizing approach to working with sexual behavior that really is concerning to people and they come in concerned, but how to approach that from a really curious, compassionate place. And so I just loved it. And then she works with Carly. They collaborate together and work kind of in a similar practice. So I'll let you guys take it from here. We're so excited to learn. No one here is AASECT certified in this room right now, but we do have some folks that, work as a sex therapist, but don't know about this modality. So this is brand new to us. So just know we're stepping in brand new and just excited. So
great. Rachel, I just tried to share my screen and it says that I think you need to enable participant screen.
Okay, perfect. Thank you so much. I will do that. Okay, you should be able to.
Okay.
Do you see that?
Yeah, it's working now.
Okay,
Let me just make sure I have my thing pulled up. Let's try it one more time. Okay. Okay. Is everyone looking at the right screen here? Okay.
That's good.
Yeah, can you see okay? Excellent. Well, thank you all so much for coming in and joining us. We're so excited to be here. As Rachel mentioned, she and I met and I felt connection and I felt very inspired when she invited Carly and I to come in to speak with you all on the subject. So we're delighted to be here. Let's go ahead and go to the next slide. We'll tell you a little bit about ourselves briefly so we don't take too much time, but we're always open for your follow-up if you ever want to consult and chat and just say hello. So
I'm Carly, everyone. I use she, her pronouns, and I have a private practice here in Seattle. We're in my office right now, and it's in the Madrona neighborhood of Seattle. I'm a licensed marriage and family therapist, both in Washington and Pennsylvania. That's where I did my graduate training. I'm an AASECT certified sex therapist. And like I said, my practice focuses entirely on working with folks with out of control sexual behavior and what we call erotic conflicts, which we'll go into during the presentation. And I also run a psychotherapy group for men with out of control sexual behavior. So I do group therapy and individual therapy, and the group meets weekly in my office here in this room.
And I also use she, her pronouns. My name is Nika, and I also have private practice here in Seattle. I practice virtually at this time, and I also supervise. My specialties are out of control sexual behavior treatment and also attachment focused therapy. So EFT is my jam. That's what I use with my couples. Emotionally focused individual therapy is what I utilize a lot in individual work. But out of control sexual behavior and erotic conflict work is a very big passion of mine. And so that's what I'm here for.
And Nika and I, even though we're not in the same practice, we met because we have the same mentor, and there's not a lot of therapists who work from this model. So we've connected that way, and it's really nice to have a colleague to refer back and forth or do case consultation with. So that's how we got connected.
That's right. So first, to start us off, we kind of assume there will be more people showing up in person, and we'll just have to kind of, based on your responses here, make some assumptions. But what we were hoping to consider here is how often do we run into representatives of this population of clients, right? So we wanted to do a very quick poll and to see, have you ever worked with a client who was showing up with feeling conflicted about your sexual behaviors?
We've got one yes so far. So you can enter into the chat or just raise your hand.
No, whatever. We have such an intimate group, so
yeah,
you don't have to.
I think
Okay,
some
so
responses came to me personally, but I'm hearing
oh,
yes.
got it. Okay, yes.
So we know these clients exist. There's actually quite a few out there.
And oftentimes they're not necessarily seeking out specialty therapy for sex addiction or out of control sexual behavior. So sometimes they're just coming into general therapy. And so we're happy to have the opportunity today to introduce you all to some ways of thinking about this, and so that you feel prepared to know kind of, what to do if you end up with a client like this in your office and you want to refer them to specialty treatment. So our goals for today, we would love for you all to walk away today being able to answer the question, what is out of control sexual behavior? We're going to talk about using a sexual health approach with clients and what that means. We're going to talk about the demographics of who struggles with OCSB and how to apply the model to different diverse populations. And we're going to be reviewing some of the core strategies and interventions within the model. And like I said, we want you to know what to do if you have a client that you want to refer to OCSB treatment. We want you to kind of know what that process looks like so that you can talk to you can walk your clients through what to expect.
So we wanted to start this conversation from considering just sexual health perspective, and language is a really big part of it. When we come into a room to have a conversation with the client, the way we speak about their sexuality and sexual health really matters. Clients come in with a lot of shame and embarrassment around these issues. And so when we use certain language, we may be, without intending to do so, right? We may be feeding into that shame and embarrassment, and we do our best to avoid that. And in fact, train clients to use different language eventually when they describe their own behaviors in order to suspend the judgment and be more open toward conversations.
Yeah, so if you hear us say, some terms you're not familiar with, sexually explicit imagery, that means porn, and solo sex means masturbation.
Or self-pleasuring, I would use for that one too.
Oops. So there's 3 current conceptualizations out there for problematic sexual behavior. There's the sex addiction model, and that model is looking for sex addiction to be included as a disorder in the DSM, as a process addiction like gambling or eating disorders. There's the compulsive sexual behavior disorder is currently listed in the ICD-11. And then there's the OCSB model, the out of control sexual behavior model. And that's what we are both trained in, what we're going to be talking about today. And it's important to note that the OCSB model is not looking for DSM or ICD approval. We view these concerns as a sexual problem, but we don't feel like there's quite enough evidence to meet criteria as a disorder. So we view it as a problem, but not a disorder, and not interested in kind of getting getting it labeled as an official diagnosis. And we'll talk a little bit more about how the model views the behavior later on today. And just for the sake of time, we're not going to be going into the other models. They definitely have some benefits to them as well. I've had clients who've worked with therapists who've gotten some really great help from other models, but we're going to be focusing on the OCSB model today.
And the thing I believe is helpful, at least it was for me when I was wrapping my head around this approach, is that it's classified as non-pathologizing. So if we call it a psychosexual problem, that means that it's solvable. It means that a client is going to work on solving the problem versus labeling themselves as with a disorder or some kind of pathology.
All right.
So we're going to go into a little bit more of a definition of what out of control sexual behavior is. And this definition is put together by Doug Brown-Harvey, who is one of the 2 creators of the model. And I actually am going to go ahead and read it out because every word here matters, and I think it is really helpful. So Doug says, Out of control sexual behavior is a non-diagnostic term to describe people who experience significant problems with regulating their sexual behavior, thoughts, urges, and negative consequences. Despite significant amount of distress, agony, shame, worry, fear, and embarrassment, as well as losses, sexual behavior and urges continue to be difficult to regulate and manage. Right? So the couple of pieces that stand out here is that people have difficult time regulating their sexual behavior. It causes pain and issues for them. They're aware of it, and yet they struggle to stop. So in order for us to work with the client, what really matters is that they themselves feel conflicted. There is motivation that client has for the work within themselves versus having to show up in our offices because somebody else labeled them with a problem or addicted and whatnot. So when clients come in with their own conflict, our job is to create space where they can explore that conflict and they can explore their conflicted motivations. They can make room for those discussions. And when we are having those conversations, we as therapists really have to work hard and be very mindful of managing our own biases. So when clients are exploring their conflict, they can do that authentically without us projecting upon them. So when they figure it out, it may look this way. For example, someone shows up, well, not when they figure it out, but more like when people show up and they say, for example, I am a porn addict. What we know from this is not much at all. We don't actually know a single thing about their situation. All we know is that that's how they're labeling themselves. So what we would do about this is start exploring what exactly is the problem, right? Do they worry about the amount of time they spend watching porn? They would say it, right? Or is it the content that bothers them? Is it the frequency? Or perhaps maybe it's their partner who is having a problem with that, and now it's a relationship issue, right? So there is room for a lot of conversation there. And maybe, just maybe they're showing up because somebody else said you are addicted and now you have to go.
This is the book that was written to really flesh out this model and sort of the training manual, so to speak. It came out in 2015, written by Doug Braun-Harvey and Michael Vigorito. Something that's important to note, right off the bat, we want to share this, is that the model was designed to help treat problematic sexual behaviors that are consensual. So if someone was struggling with any non-consensual sexual behavior, if we learned that in our assessment with this client, we would really respectfully and empathetically refer them to a provider who's trained in working with non-consent. We believe it's really important to kind of stay in our lane and not try to treat people where we don't have that training or those skills. So what we would refer them, if someone was struggling with non-consent, we would refer them to what's called an SOTP, a sex offender treatment provider. And SOTPs are trained to work with folks who either have gotten into legal trouble before because of their non-consensual behaviors, but also people who maybe have offended but never, it's a major issue. They haven't gotten in trouble. It's not been a documented concern. And so the SOTPs are trained to kind of help assess for risk of reoffending. And so they're really the kind of the experts who can work with and make sure that they're going to be safe, with their partners or people around them. So we focus on consensual, out of control sexual behaviors. The OCSB model views, these concerns as like Nika said, a problem. So we believe there's a continuum. On one end of the continuum, there's sexual worries. On the other end of the continuum, there's sexual disorders. And in the middle, there's what we call sexual problems. So an example of a sexual worry would be, when am I going to have intercourse for the first time? Or will my partner be turned off by my body odor? Or I'm worried I'm less interested in sex since having a baby. Those are all examples of sexual worries, which everyone has from time to time. On the other end of the continuum, we've got disorders such as erectile dysfunction, premature ejaculation, things like that that are pretty well documented and well studied. And we believe that out of control sexual behavior is kind of in the middle there as a problem.
So to get you all kind of imagine a little bit more what this work looks like and population looks like, we brought in 3 case examples that are made up. These are not real people, but we are creating these sort of vignettes for you to get an idea. So for example, a person who would walk into our office for treatment could be Alex here, a 37-year-old, cisgendered, white, heterosexual, married man. And his wife is upset because she recently discovered he has been going to massage parlors and receiving orgasms from the providers by manual or oral stimulation.
Another little vignette, we've got Roger, who's a 46-year-old gay, Asian, cisgendered male. He's in a long-term committed relationship with his partner. He has a long history of fascination with BDSM and kink, specifically power exchange, in which he is a sub. Roger's partner was furious when he discovered that Roger had been paying a dominatrix while they had been trying to experiment with BDSM in their own relationship.
Another case example here is Paul, 29-year-old heterosexual cisgendered Hispanic male with distress due to relationship conflict. He started looking at sexual images in high school in order to distract himself from the sounds of his parents yelling and fighting. He was presenting in therapy as his current girlfriend discovered him looking at sexual imagery and demanded he gets treatment for his porn addiction. So all of these clients may show up in our offices, and each one's path, clinical path in treatment may look different. They do share some intersectionalities here. All of them seem to be motivated to show up in treatment. They're experiencing relationship distress, and their relationships are important to them. And yet they are conflicted and struggling with behavior that is pleasurable to them and the consequences of the behaviors. And often in these situations, partners feel betrayed, right? So this is an important piece of it. Partners feel betrayed, and the partners who are engaging in out of control sexual behavior are having difficulty being honest. So we will touch on all of that in the presentation.
Yeah. So we're going to talk about what leads to OCSB next.
And this portion here, this slide, is regarding 3 different areas in which out of control sexual behavior may be showing up. And it can be shown up in areas 1, 2, or all 3. So this is something to consider. It's not just 1 or all 3 necessarily, it's any combination. So out of control sexual behavior could be as utilized by a client as way of self-regulating. So they might be having difficulty with self-regulation when they're experiencing emotional dysregulation. This is the way they soothe themselves. And another way to see that is through attachment regulation lens, where people have, due to their histories, just other than secure styles of attachment. And so when they are running into these contradictions, out of control sexual behavior shows up. Erotic conflict is the 3rd area. And this could be kind of demonstrated in the statement, what I like sexually is not what I should be liking. So this internal conflict is a part of the picture, and out of control sexual behavior exists in that role. Again, could be one area for any particular client or all 3. And the good news is that OCSB therapy modality is prepared to treat all of this.
Right. These are all things that can be worked on in therapy, like attachment style, learning how to regulate emotions, and releasing some of the shame around the erotic conflict. And kind of deciding, is this a turn on that I actually want to integrate, in my life, and learn how to accept it more, as opposed to needing to go practice it in secret because I'm ashamed of it. Rachel, do you have a question?
Yeah, will you just say a little more about the love versus lust dichotomy in attachment? What is
Sure. Yeah. That's sometimes we have clients come in where they might feel like there's a split between who they love is not who they lust after. And then likewise who they lust after is if that's not who they would feel safe, having an emotional connection with. And so they're kind of having to navigate, okay, I have this split. How do I integrate this? How can I more eroticism in my relationship with my partner where I have that emotional intimacy with? Does that make sense?
And maybe another thing to add here, if people typically get curious, so how do you, like, this seems overwhelming, this is so much, like, how do you even tackle all of this, right? And a few ways in which we would go about it. Motivational interviewing is a very big part of out of control sexual behavior work, because we look at a change on the continuum and we take great care to stay with the change stage that client is currently at. So we do interventions timely to where client is at in their continuum. We do mindfulness work and emotional regulation work, a lot of that, and also a lot of attachment work. And that's the treatment sort of lens, but I wanted to mention that, I guess, because we're presenting so many components that are problematic, and then one might think, so how do you
where do you even start? Yeah, a lot of here and now intervention, so training clients to pay attention to their bodies and their physiological responses, their breathing, things like that, because a lot of times these clients can be totally disconnected from their feelings and their bodies. They're living kind of like from the neck up, so to speak. There's 4 vulnerability factors that we always assess for with new clients, because these 4 things can make clients more susceptible to out of control sexual behavior. So that includes substance abuse. So if a client is abusing a substance, as we know, substances can lower inhibition. So sometimes there can be sex and drug linked behavior or sex and alcohol linked behavior. So these are things that we would want clients to be, if we find them find them during our assessment, we might refer clients to concurrent services so they can address this. Because it can really kind of stall their progress in therapy if these things are left untreated. The next one is mental health concerns. So if there's any sometimes untreated depression or anxiety can lead to more coping with out of control sexual behavior. And then we also know there are some mental health disorders where the symptoms are sexual impulsivity, such as bipolar disorder. So we want to make sure that we're assessing for that, so we're not missing something that's a clear contributor to the out of control sexual behavior. So we might refer folks to a psychiatrist or someone who can treat the bipolar disorder, for example. And then the next one is physical safety concerns. So if someone does not have a safe place to live, if they're houseless, or if they are in a domestic violence situation at home where they're the victim. I've also seen folks where they're living with a partner where the partner is really struggling with suicidality and suicide attempts. So the home just feels really unsafe. That can make someone more susceptible to coping with sexual behaviors, self-soothing with sexual behaviors. So we want to be screening for these things as well, and helping clients establish safety so they can actually engage in therapy in a helpful way. And then the last one is underlying medical concerns. So there are some medical conditions that can make someone more vulnerable to OCSB. I've seen that with traumatic brain injuries. I've also seen, interestingly, there are some medical conditions where the treatment for the medical condition can lead to sexual impulsivity. So Parkinson's disease, for example, there's the medications that are used to treat it. The medications have side effects that can cause out of control sexual behavior. So I've seen that in clients where they weren't having any trouble with out of control sexual behavior until they started a medication, and then all of a sudden it emerged. We want to make sure that we're screening for that, so we have a good sense of what the full picture is. And sometimes that will require us to actually collaborate with the client's doctor and advocate for, can we switch their medication? Is there a medication that has fewer side effects that they can go on? And sometimes that, is a big part of solving the problem. Sometimes there's situations where there's not another option. People can't switch their medication. So OCSB therapy would be appropriate to help them just manage those side effects and come up with a plan to make sure that their sexual behaviors are aligned with their values and their relationship agreements and all of that.
Do you all have any questions or any comments at this point? So we're not just talking at you for the whole hour, and we will have Q&A time at the end, but I wanted to make sure we create space for anything that's coming up right now.
We have a few questions just to kind of
Yeah.
want to go first?
Sure. I feel like maybe you already answered this, but I'd be curious to hear how out of control sexual behavior is differentiated from OCD.
Oh, that's a great question. Yeah, there's definitely, I actually took a really great CE course last summer on differentiating between OCD where there's some sort of sexual component to the obsession or the behavior, or the compulsion, the obsession or the compulsion, and differentiating it between out of control sexual behavior. I definitely get a lot of clients coming in saying they are feeling out of control with their sexual behavior, and then when we explore it a little bit more, it feels like an OCD symptom instead, and so I will refer them to OCD treatments. So some examples of that could be a client is a really common one is a client's coming in and we're also kind of assessing for if they're worried that they're having sexual thoughts about minors. You're assessing for a lot of things, because we're like, okay, is this OCD, or is it a true, attraction to minors? And are they at risk? Is it, can they manage that attraction, or are they at risk of actually offending? So, with our model, we're not really trained to differentiate are they at risk of offending? So we'd want to refer them to, if we do feel like it's an attraction to minors, we would refer them to someone who works with that population. But sometimes we won't even get there, because I'm like, it's pretty clear that this isn't an actual attraction. The thoughts are they're not pleasurable thoughts, they're intrusive, unwanted thoughts.
Right.
So it's called POCD, where people's OCD is worrying about being attracted to children, but they're not actually attracted to children, and they do a compulsion of maybe avoiding children because they're so scared about this, or they're monitoring their thoughts, or they're monitoring their response to children. But it's not that they're attracted to children at all, it's an OCD symptom. So it definitely helps to be able to differentiate between what's OCD, what's actually attraction to minors, and what's out of control sexual behavior. Because I've seen it show up in a couple other ways where, someone's having a lot of sexual thoughts, but they're not actually pleasurable. They're unwanted. They're disturbing to the client. Does that help answer your question?
Yeah. So ultimately what we're looking for is like, if it's intrusive versus pleasurable, even if the shame.
Exactly. Yeah.
Exactly. Yeah.
That's it. That's the way it clicked for
Yeah.
me.
I think the term is like ego dystonic versus dystonic, I think.
Okay.
I'm sorry to interrupt.
Yeah, no worries at all. That's you're right on there. I think the way to distinguish is OCD is about discomfort and eliminating discomfort with the behavior. With behaviors that are within the realm of out of control sexual behavior, they are behaviors for gratification.
Mm-hmm.
Gotcha. Thank you so much.
Yeah, great question.
Super great question.
I have a question quickly about how sexual trauma fits in here.
Yeah, that's a great question. We can go back a couple slides. So we actually do give in our assessment that we do with clients, we do have them fill out the ACE, the Adverse Childhood Experience Questionnaire. And we find that clients who score high on that's an indication that there's past trauma that might be contributing to oftentimes it can show up with the attachment work, but also in the self-regulation category here. They might be struggling with some PTSD, which, and struggling to regulate their emotions or regulate their physiological responses because of that. I will say that not because if this framework is, if a client's struggling with OCSB, we know they're struggling in at least one of these areas, but sometimes, they might not all of them. And so similarly, like sometimes a client will have a high ACE score, a lot of childhood trauma, but we see clients all the time with OCSB who score really low on the ACE as well. So everyone kind of has their unique clinical picture of what are the contributing factors to their experience of the out of control sexual behavior. Does that make sense?
Yeah, it does. Thank
Cool.
you.
And in this work, I would say we don't do trauma-centered interventions. We stay, once again, we stay in our lane, right? So if we end up having a client who is getting incredibly dysregulated because of the trauma history and getting cued in, and that is interrupting our treatment process, we will address that, and we will potentially involve concurrent EMDR therapy or something, we will then address it. But OCSB modality is sex therapy modality. So we don't then switch and do trauma work. We incorporate trauma as a part of the clinical picture and what that means for clients' sexual behavior. That's the lens we look through.
Sure.
I see. Okay. Thank you.
Yeah, they're great questions.
All right. So we're now going to be talking about the OCSB model and what makes it stand out, right? Like we mentioned in the beginning, there are different ways of approaching problematic sexual behavior. Why out of control sexual behavior model, sexual health focus model is the model Carly and I chose to invest into training in and really apply ourselves in. So what is distinguishable about this model is that, once again, it works only with consensual behaviors. So for example, behaviors such as exposing own genitals in public or peeping through the windows for sexual gratification, attraction to minors, whether it's behavior or consumption of sexual imagery involving minors, obviously sexual assault, perpetrating sexual assault, all of those behaviors are examples of non-consent. And these kind of behaviors need to be treated by people trained in working with non-consent. Sexual, out of control sexual behavior model, sexual health focus model, focuses on approaching behaviors through the lens of ethical principles and not acts. So we are not in a position as therapists to determine what sexual acts are appropriate or not appropriate for any human being, right? That's why this is exactly why this non-consent is excluded from the model. So then we can have freedom, knowing that, all right, we are reassured that behaviors are all consensual. So we now can allow for the client to fully take space and explore their sexuality with our support and guidance versus us telling them this is okay and this is not okay. So we do not, also important part is that this model does not pathologize high sexual desire. Every human being has uniquely their own way of excitability. Some of us are more so, some of us are less so, based on our nervous system. And so the issue is where clients, and typically out of control sexual behavior clients, are the ones with, we call them high exciters. They typically have nervous systems that are capable of high excitation. And
it doesn't take much stimuli to respond with a
quick
result.
and they go high, right? So then the issue becomes when they're not able to regulate that. So the issue is not their ability to experience high levels of arousal. The issue is with regulation. So that's where the work is. And We do not pathologize diversity of sexual expression and people's choices around their relationship structures. We don't pathologize non-conventional turn-ons and such.
Mhm.
Would you like to add anything?
No, I think you got everything there. Yeah, so, and I think the Doug Braun Harvey and Michael Vigorito, they started this work in the early 90s. And so they are both gay men, and they were working with a lot of gay men at the time. And they wanted a space where people who, believed in consensual non-monogamy or ethical non-monogamy could hold that value, and also get help for feeling out of control with sexual behavior. So that was sort of the genesis, of this model.
Right, and also people who are in these monogamous normative kind of structures, they also benefit from this model greatly. So there is a very high applicability. Is that how we would say it?
So often when clients are coming to this work, the goal is of the model is to help them find sort of healthy expression of their sexuality, but who gets to decide what healthy means, right? What does that mean? What does it look like? Historically, religious institutions would define that for people, and they'd say these sexual acts are moral and these ones are immoral. And also in medical settings, sometimes sexual health or in sex education, sexual health is viewed as, the absence of getting a sexually transmitted disease or, an unwanted pregnancy. But in the sex therapy world, we believe sexual health is about more than just the absence of disease or unwanted pregnancy. Doug Braun Harvey and Michael Vigorito came up with these 6 principles to kind of use as a rubric to help clients evaluate their behaviors. So we can help a client, with any particular sexual behavior, we can ask, does it meet these 6 principles? And if it does, if the answer is yes, then we can consider it healthy, sexually healthy, right? So this is a poster. It's actually right over there in my office. It's a poster of the 6 principles, and I always have it within the line of sight of my clients of where they sit, so that we can just constantly be referring to it throughout the work. And I find that really helpful. And, as clients progress in treatment, it's like music to my ears when they start to incorporate this language, and they might come in and say, I had a sexual experience that wasn't a boundary crossing, but I don't feel like it met the 6 principles. I don't feel like it, there was safety, or I don't feel like there was, aligned with my values. So that's really great when clients start to integrate this. So we're going to go through what the 6 principles are and what they mean. We've already talked a lot about consent. So we can ask, is the behavior consensual? In this context, when we talk about consent, we're talking about the people who are actually involved in the sexual act. Are they consenting? Sometimes people will come in and they'll be like, well, I went outside my relationship for sex and my wife didn't consent to that. And that's a fair point. That's true. But in this context, when we're talking about consent, we're talking about the person who you had sex with. Were they consenting, right? Or were you consenting? So that's the first one.
Or, if we're talking about consumption of sexual imagery, I get the question a lot because, when you're a consumer of pre-recorded material, you're not necessarily engaging with someone who is actively there. Nonetheless, the same principle stands. For example, consumption of sexual imagery that involves minors, right? Minors by law are not able to consent, so therefore it's not consensual.
Right. Or if there's if the sexual media is footage from a camera placed in a public restroom where people don't know they're being filmed, that would be another example of, consent not being present.
So next principle of sexual health is non-exploitation, and people confuse consent and non-exploitation or exploitation, non-consent and exploitation, and consent and non-exploitation often. And the way to distinguish here is that Exploitation is when you're leveraging your power to get access to sexual gratification or sexual resource, right? So a good example of that would be, for example, a person in position in leadership having sexual interaction with someone who is under their leadership, right? So that's one example. Another more common way of encountering exploitation, however, is deception. So if we consider in relationships, someone will break in or going out of relationship agreement without their partner's knowledge, this person then has to come back to their primary relationship and make it so that it is not known to their partner that relationship was broken. So therefore, they are utilizing leverage and trust to get away with something that their partner otherwise would have a big problem with, right? So this is how we see actually exploitation showing up in our clients' stories, probably most often speaking for me.
Totally. The next one is protection from STIs and unintended pregnancy. So pretty self-explanatory. There was a wonderful book that came out in 2023 called Ejaculate Responsibly. And the author was making an argument that 100% of pregnancies are caused by an ejaculation. So why don't we put more onus on people with penises to prevent pregnancy? The way I've sort of tried to incorporate, that way of thinking into my work with these clients is I like to ask all my male clients, what's your contraception plan? And I don't look at me with like deer in the headlights. They're like, what? Like, I don't have one, or I didn't know I needed one. Because they're so used to not thinking about that. And they'll often say things like, if they're having sex with a woman, or someone with a uterus, they'll say, well, I just assumed that they're on the pill because they didn't say anything. And I'll ask, how comfortable are you not knowing? And so these conversations start to kind of get clients to think about their own risk tolerance and their own comfort. They're often not processing their how they feel about potential consequences in the moment. And so these are great conversations to have with folks to help them kind of identify, okay, like what are the conversations you want to have first before having a sexual interaction? And what do you want to be, a lot of times some of the conflicts that people are having is they're engaging in sexual behavior and then afterwards they're realizing, oh, that was a risk I wasn't comfortable taking. And so that's where their conflict is with their behavior. And so we're helping clients sort of be sitting with the risk, contemplating the risks they're taking in our office and really processing how they feel about it. What is their comfort level with that?
Absolutely. So next one is honesty, and honesty came up when we were talking about the case examples, right? Where a lot of times in relationships, people have difficult time with honesty when out of control sexual behavior is involved. So part of OCSB therapy approach is to teach people that to make the difficult choice toward honesty, right? We actually have a lot of conversations with clients about it. We thank them for honesty, and we make a lot of space for conversation and discovery around why it was difficult to be honest when they are able to admit it, be dishonest.
Yeah, we celebrate when they practice honesty with us in the therapy. We really celebrate that and also explore like what motivated you to be honest today.
So that would then apply to their personal life, right? Because eventually we would want, if people are in partnered relationships, we want them to be equipped and practiced enough to be honest, to bring the partner on board with their sexual health plan and with things that they're struggling with.
The next one is sexual values or shared values. So everyone has beliefs about how they want to be out in the world and how they want to show up in their sex lives, who they want to be sexually. And those are our values. So we can ask clients, was this behavior aligned with your values? And that might require some exploration, identifying in the therapy, what are their values? And then we can also ask, do you share the same values with your partner? And was this behavior aligned with your partner's values? That's where the shared piece comes in. A good example of a sexual value is how people feel about sexually explicit imagery online. So some people might view, when you're in a, their version of monogamy, if you're viewing sexually explicit imagery, that might feel like cheating or infidelity. Other people might have a totally different value around it. They might feel like it's fine. I don't, it doesn't bother me if my partner does that. They can do what they want with their body and their own sexual pleasure, as long as it's not crossing a boundary, right? So those would be some examples of really different sexual values. So this is kind of a nice framework to help folks start to kind of view, if they're having a lot of conflict in their relationship about this, we can kind of help clients identify what are your values around sexual imagery and how do you navigate it if you think you have different values than your partner. Oftentimes clients in that situation will agree to avoid conflict. They'll agree to agreements in their relationship that they're not really actually equipped to keep. And then they don't want to be honest about it because they're avoiding conflict, right? And so this kind of gives a helpful framework to start to identify, okay, what are some other options of how to navigate this values difference in a relationship?
Another example, I would say, of shared values that has come up for me that I think is helpful to consider is engaging with a partner, for example, in a situation where client is going outside of their own relationship and engaging in affair with another person. What is the expectation around the sex and what is the expectation around the meaning of sex in this particular interaction? Is their partner who they're engaging with sexually outside of their marriage expecting for them to leave their marriage and be with them now? And maybe this client is only seeing this interaction as, this is for sexual gratification. This is not a big deal. I'm certainly not leaving my family, right? So there's a lot to talk about there. Mm-hmm. Because there's no alignment in values. And Doug said this phrase once, and I really appreciated it, is if there is no shared values, there is no relationship, right? So it's not possible to actually claim you have a relationship with values that are shared.
Oh, you're the next one.
Oh, I'm next. I'm making a pause now. So the last principle, not the least whatsoever, is pleasure. And pleasure is incredibly important, and sexual health focused model of treatment makes space. The definition of sexual health involves the word pleasure. Because pleasure is really important. We are wired to seek pleasure. It gives us a sense of well-being. It's good. We all deserving of pleasure just by the birthright. The question is your pleasure and your behavior to derive pleasure, are they aligned ethically with your life values, right? And that's what this work is all about. It's about balancing pleasure and safety and balancing pleasure and all of the rest of these components, because often clients who come to us, they would only be able to say that they're meeting two principles of sexual health. They are pretty sure it's consensual, and they're certainly seeking pleasure and derived pleasure. The rest is problematic, and that's what we're here for.
Mm-hmm. All right, so we're going to talk about who struggles with OCSB next.
So Carly mentioned earlier that Doug and Michael started practicing this model and really figuring out this model in the early 90s. And when they did their work, the research that they were going with and were conducting, it all involved cisgendered men. So when they were presenting this model, it is in order to do no harm. Their claim is that this model is designed for cisgendered men of all races, ethnicities, and other intersectionalities. However, it was very gendered, non-diverse, and non-binary folks were not included. And so it kind of created this false impression that this model may not be applicable outside of cisgendered male population, and also that this is the only population that struggles with out of control sexual behavior. So since then, there has been a bit more movement, and Carly's going to talk about that.
Yeah, there was a research study done in 2018 in which they had a pretty nationally representative sample of about 2,300 people. And they asked these people to report on feeling distress or impairment associated with difficulty controlling sexual feelings, urges, and behaviors. And the results kind of were surprising. It was very different than the research that had been done in the early 2000s and 90s on it. It showed that the gender difference was much smaller than we previously thought. So men were 1.5 times more likely to report that distress, but women still accounted for nearly half of the distressed participants. So that's, and anecdotally, I do have colleagues who work with OCSB who are seeing, more women coming into their practices. So, that tells us right there that we want to be, making sure we're adapting the model to work with women. And then this study also showed that racial and ethnic minorities were about twice as likely as whites to report this kind of distress. And sexual minorities were about 3 times more likely to report this distress than heterosexuals in the group. And the authors of this paper, their interpretation of that was that there's, as this idea of minority stress, that being a sexual minority or racial or ethnic minority in this country comes with a lot of more stress of dealing with that, being, in that position, in a position of being disenfranchised or marginalized, right? And so that can lead to more coping with out of control sexual behavior. And this study did not include trans or non-binary folks, but I think we can think, I also anecdotally know OCSB therapists who are seeing some trans and non-binary folks in their practice. So I think we can conclude from that minority stress finding that there is a need for this work in those populations as well. And so that leads us to, how do we adapt the model to be applicable to other populations? A sex therapist named Jessica Levitt, she wrote a paper adapting the model to work with cisgender women. And what she argued was there's nothing about the model that is not applicable to, any population. It's just the principles are going to be applied to everyone, right? Everyone's got sexual values they can identify, they can use that rubric of the principles. But she argued that you just need to make space for exploring women's experience living under the patriarchy, basically, and dealing with sexism and making room to explore that in the model and how that impacts them. And so, we can concur that would be applicable for non-binary and trans folks as well, but we obviously need folks who are experts in working with those populations to kind of weigh in and maybe do a little bit more research on translating the model.
So we have this last section ahead of us just to review a bit out of control sexual behavior model core interventions. And again, I want to pause slightly here and see if anything is coming up for you all and you'd like to share, or maybe a question you would like to ask now.
One of the things that was coming up for me in the study that you were talking about with Gleason, Dickerson, and somebody else, it was making me think of is it so I thought about definitely with racial minorities, thinking about reporting more distress and actually seeking help might be the component. When racial minorities have to have a very big trigger to seek mental health counseling. And or I think about the intersection, especially with racial minorities, Black, Asian, Latino, with religious, right? So how that conflicts with how it intersects with religiosity and religious communities. They tend to be pretty highly religious communities. And how that intersects with the distress that may be being seen, and if distress is the factor that people are coming to seek, rather than more like a couples because they may be, I'm thinking are they seeking it because they're feeling more in distress, and that's what that study was looking at, versus their partner is pushing them to go see a counselor because of that. So that's what was coming up for me.
Yeah, you nailed it in terms of, you made some really good points that there's there's been some really interesting research on like which populations are feeling more or reporting more like sex addiction or like distress about their sexual behaviors. And in communities where there's more like religious communities, there's higher rates of distress being reported. And so you can think of that as like, there's like a moral incongruence factor there, where if your values are more, you know, if you believe that looking at sexual imagery is a sin, right, then you're going to feel more out of control if you're looking at it, right? So that's definitely a factor. And then, yeah, you made a really good point about the paper is just asking self-report about, do you feel distressed about this? And it doesn't look at who's actually accessing services. And so that would be an interesting study as well to look at, like who's showing up who's seeking out the OCSB model versus who's maybe seeking out more faith-based resources for sexual concerns. I think that'd be really interesting to look at.
Yeah, because when I think of like so I'm thinking of like even more like Mormon communities, LDS communities,
Wow.
those kind of communities are not going to seek services and also will likely not report stress at all, because they only would go see a religious, you know, they would go see a church leader on
Right.
these, and they would either be punished or helped, whatever that looks like in the community, for those. So that's big, not large, hugely large swaths of the community, but those are communities that would not even be reporting stress. It's the same. I was doing an intimate partner violence class in grad school, and the highest is with people who are married to law enforcement, but they don't seek help because they're married to law enforcement, right? So looking at that kind of model, folks that we're just not going to see very often.
Yeah, they don't see an option, right? They see themselves as locked. Yeah,
Mm-hmm.
absolutely. Such a great point. I'm grateful for you bringing this up.
Mm-hmm. All right, so the OCSB model was designed as a combined treatment model, combining individual therapy and group therapy. So not everyone who comes through our offices is going to be a good candidate for group therapy. So that's part of what we assess for is, are we going to recommend, you know, the combo of individual and group, or are we just going to recommend individual? People can be in individual therapy weekly or biweekly when starting out. The requirement to be in the group is that you're just attending individual therapy at least once a month, and it can be with a therapist that they're choosing. So if someone's getting towards the end of their treatment and they made a lot of progress and they're more on a maintenance schedule, you know, with therapy, they just have to go once a month to stay in the group. The group meets weekly, and the group is a really wonderful place to practice keeping agreements. So everyone who joins the group has to have what Nika is going to talk about in a moment, a sexual health plan where they identify their boundaries, their sexual boundaries. And the agreement is if they cross one of those boundaries, then they will practice honesty and disclose that to the group at the next group session. So there's that accountability there. And oftentimes that is a pretty big deterrent for clients, because I've heard clients say, like, you know, they're about to have a sexual interaction and they're like, ah, crap, I don't want to talk about this. I don't want to have to talk about this with the group next time. And, you know, so it'll be a deterrent. And even if they, you know, if they're like, they decide that they don't want to talk to the group about it, then they're sitting in the group with that discomfort of knowing I'm not being honest about this. And eventually that, you know, that comes out and they get to process that. The group's also a great place for folks to practice being open about their sexual pleasure and erotic conflicts. So if they have a turn on or less conventional turn on that they're feeling a lot of shame about, the group is a really safe place where they can start talking about that with folks, because oftentimes our clients are like, I've never told anyone this before. So it's a place where they can kind of work on releasing some of the shame around it and joining with others who might have similar interests or, you know, another unconventional turn on. And then lastly, the group is a really wonderful place to work towards developing secure attachment. So we do a lot of processing the relationships within the group, encouraging folks to be open about how they're experiencing each other and their feelings towards each other. So it's a really special place.
Yeah, it becomes a really big support and resource for clients. So when I work with individual client who's in group, and Carly is running the in-person group, like she said, I'm planning to run online group here in a bit. So when clients talk about their sexual health and their treatment progress and their experiences, I hear a group coming up in a way that is clearly valued, and it's a very, very special thing, like Carly said. And it makes sense because we are all attachment beings, right? We're wired to belong. And if we don't belong and we feel ostracized and not a part of human community, it's a very specific kind of pain that is very deep, again, because of our wiring toward attachment. So when people can have a safe place to be and bring parts of them forward that are not pretty parts, and maybe they're really conflicted around whatever they are to share, but it is safe to share, they get witnessed. And when we get witnessed as human beings, we heal. So it's powerful, powerful thing.
That was well said.
All right, I love this diagram. It looks like a spaceship, I always think, but it's helpful. It's helpful, I promise. I'm not going to go super in detail here, but we'll just kind of follow the cascade a little bit. So typically, just so you have an idea of what this modality kind of process looks like from the beginning. So typically, client comes in, we see them for a screening session, and we figure out kind of what their motivation is, and we also screen for non-consent. So we, the one reason why we might not recommend assessment would be running into knowledge of behaviors that are non-consensual, and then we refer out. Provided they do meet the criteria, we recommend assessment, and the client gets to choose if they'd like it or not. They go forward with assessment. Typically takes about 4 sessions for us to go through the process. It's very structured. It's incredibly rich for the client to go through. It's not just us getting to ask difficult questions and they have to report. They learn a lot about themselves in this process. And sometimes clients just come for the assessment, and Carly will talk about assessment here in the next slide more. Once client has gone through the assessment, we at that point are able to clinically conceptualize what their story looks like, and we're able to determine whether or not they're struggling with out of control sexual behavior, or perhaps this is just erotic conflict, not just, but this is an erotic conflict. And so we make our recommendations for treatment based on what we discover. And at that point, client gets to decide how they would like to proceed based on the recommendation that we make.
Right. They can just take what they learned in the assessment and go see a different therapist or go back to their referring therapist, or they can decide, do I want to start the OCSB therapy? So what we're looking for in the assessment, we're asking, does the client need to be referred out due to non-consent? We also are looking for, is the client motivated to change? So are they here? Are they coming here because someone else, they're ticking a box that someone else is, wanting them to come here? Or are they motivated to making a change in their behavior? They might not know how to change their behavior yet, and that's okay, but are they wanting to change the behavior? And oftentimes, like our vignettes sort of show, oftentimes clients are coming in because there's been a discovery of a betrayal and the relationship is in crisis, and they're coming in and their motivation is, I don't want to lose my partner. I want to save my marriage, or I want to save my relationship. And that counts as motivation, because that can be really powerful motivation for folks, the fear of loss, right? So that would be that would count as motivation. If they were saying, I'm not ready to, I don't want to change. I want to keep doing this. I want to keep deceiving my partner, but I'm just here so that they think I'm getting treatment. That would not count as being motivated. That's more like, being here to just tick a box. So we're assessing for motivation. We're asking, does the client need to be referred to concurrent services? So again, those are those vulnerability factors like mental health, medical conditions, things like that. And then we're exploring which of the clinical areas does the client struggle in. So are they struggling with self-regulation, attachment regulation, or erotic conflicts? And it's a mix of interviews and questionnaires to determine those things. And ultimately, we're asking the question, is OCSB treatment recommended? And are we going to recommend the group therapy component as well?
Right, so here's the sexual health plan slide, and the power of sexual health plan is that by the end of the assessment, client has learned enough about themselves and has faced enough of the conflict to know whether or not they would like to commit to a change. Again, like Carly says, we don't know yet how, they don't know yet how, but do they actually see a problem they would like to fix? And if so, then they get to determine what kind of boundaries they are ready to put down for themselves. So in other words, what kind of behaviors they are no longer interested in going for. So sexual health plan is a place where that can be stated in a very clear way, where there is no ambiguity, where it's very specific to a client's case, it's their own language, and it's their own document that they own, right? So this is something that's for them, and they get to create it with our help. So boundaries is one section there. And another section is ambiguity. Sometimes people are not sure yet, right? This is very normal, where someone is thinking, well, I actually enjoy viewing sexual imagery, but it's causing so much pain in my relationship. I gotta figure out how to make this work. But they are not in a place where they're saying, this is unacceptable for me. I no longer wish to be viewing any, right? So this is a place for ambiguity, and it's a wonderful, we want to have items there. We want to have considerations that clients are going to be interested in reviewing.
Right. We don't want them to set a boundary that they're not prepared to follow through with yet.
Exactly. So then there is the third component of sexual health plan is actual sexual health. So what kind of things you would like to start doing more of or begin doing you haven't been doing before? That could be around specifically sexual behavior. I will only want to have sex with such partners or whatever else it may be. Or it could be items around supporting their wellness, because when we are not well, we're not sleeping, we're not eating, we are overworked and whatnot, our capacity for correction of the course is so much lower. It's almost like this, what our mentor calls allostatic energy, is when, you know, you trip or you slip and you catch yourself. Your ability to catch yourself, that's what we want to nourish. Because if we are broken down and we're barely holding on, we are going to fall on our face much easier. So there is a portion in sexual health plan that covers that. And so the idea behind sexual health plan is, again, to establish commitment to behavioral change, but also it introduces point of accountability. Okay, now we have named what we are working on, and now we can talk about challenges that naturally come up when we are approaching the change.
So the OCSB therapist really becomes the accountability partner for the client, as well as the group, you know, is part of that accountability as well. And so it can actually be a real relief for the partners of the client to not have to be the cop, right? They can trust that my partner's in treatment, they're accountable to their therapist. I don't need to be, you know, in that position, like monitoring them so closely.
Right. And so it's interesting because the model seems to be it is so sex positive. It may seem permissive in a way, but it's not. There is the honesty and accountability are incredibly solid pieces of this process. So vision of sexual health is what client would like to work toward, right? What is it that they would like their sexual life to look like when it is balanced and is in congruence with the principles of sexual health, in congruence with ethics? If you don't know where you had it, how the heck are you going to get there, right? So we work on figuring out what is it their clients wish to see for themselves, so they may have that goal.
So this is a second document that they create in the therapy. So those are often the first two things we do, you know, once we get through the assessment measures, is creating these two documents.
Right. It's kind of like a way of centering into treatment. That's how I see it. And if client does if it's one of those cases where client comes to us for an assessment and their plan is to return to their treating therapist, whoever might have referred for the assessment, just to gain information, being like, hey, you know, I'm not trained in this. Let me send you to someone who is. They can help you understand, get something out of it, and then we will continue the work. That's completely appropriate. And so when client comes back to referring therapist, they will be back with those two pieces of information.
Right. which goes right into our next point, that we're always happy to, if a client wants to stick with their referring therapist, we're happy to consult, share what we learned about the client in the assessment, what we think would be helpful. But we really believe that it's important that clients have, once they get past the assessment, it's most effective for people to just have one therapist. It can kind of dilute the therapeutic relationship if you've got more than one, and just can get kind of confusing for clients. So if someone is really committed to staying with the individual therapist they had and the referring therapist, we want to support that. So we're happy to, conclude our time with them after the assessment and then consult with the individual therapist as they go back to that therapy. Or people have a choice, if they're like, I think I want to work with an OCSB specialist going forward, they're welcome to stay on after the assessment, but we would just recommend that they wrap up their other therapies so that they're not having more than one. We also do a lot of, we wanted you all to kind of know what to expect if you refer, that there's some decisions to be made with your client around, they want to continue with you after, they want to work with us, and we're happy to support whatever, is best for the client. We also do a lot of collaborating with couples therapists, as you can imagine. So relationships are often in crisis when clients are entering into this work. So it's really important for them to have that support of a couples therapist. Ideally, a couples therapist who's familiar with the model and kind of knows what to expect from the client's individual work. And so we do a lot of consulting there with the couples therapists and letting them know, what would be helpful for the couple to be talking about in their work and vice versa. And then lastly, when folks are in group therapy, they're allowed to have a therapist of their choosing. Everyone has to go through the process of the assessment and making a sexual health plan and a vision of sexual health. But then if they want to continue on with their previous therapist, they're welcome to, and they can be a part of the group. So we would just do some care coordination between the group therapist and the individual therapist if that was the case. A lot of the folks in my group are in individual therapy with me, so I'm both their group therapist and individual therapist. But every once in a while, I have someone who, wants to stick with their original therapist, and it works pretty well to just check in every once in a while. All right, so that's our presentation for today. It looks like we've got 15 minutes left for any questions, and we're happy to. I know that this presentation was being recorded. We're also happy to share our slides so that you all have them if you want to refer to them. And we've got our contact info on here, so you're always welcome to reach out and ask questions, or share our contact info with anyone who would be interested. But yeah, does anyone have any questions?
We don't see everyone there, but you're
Okay, let me
not able to see.
Okay. Stop sharing too.
I have a question about like the erotic conflicts back on one of the three clinical areas slide. It made me think of, I heard Cheryl Strayed, the author of Wild, talk one time about this erotic conflict she had where, she's like uber feminist, and she's like, what gets me going is this fantasy of I'm in lingerie serving appetizers to a bunch of dudes watching football. And she's like talking about how nothing about that aligns with her values, but the fantasy of it. And just, can you, like, how do you end up kind of working with clients in those, like, to integrate, maybe what physically is arousing to them and where their values are, like what's your next step as you kind of untangle some of those differentiations? She was clearly comfortable with that in herself. She'd done a lot of obviously integration and was laughing about it, but I'm just curious in that kind of, how you can
sometimes it definitely we do a lot of like parts work in this therapy. So exploring like the different parts of a client. There might be that feminist part that's, uncomfortable with it. There might be the pleasure seeking part that finds it really erotic. So we work with those with a lot of parts language. I also sometimes will provide just some education on fantasy and like the nature of fantasy, that sometimes fantasy is not politically correct. It's a place to kind of be, free from the constraints that you would actually have in your life, right? And sometimes people have fantasies that they wouldn't actually want to enact in real life. It's just a place where they want to, that's pleasurable to fantasize about.
Mm.
Some folks are the opposite, where it's like their fantasies do reflect what they would actually get pleasure from in their life. And so we just explore that with the client of, is this something that's just erotic to think about, or is it something you would actually want to do or explore? There's a book by Jack Morin. He talks about the 4 cornerstones of eroticism. So he says every fantasy can kind of be described by these 4 categories. And one of them is he calls it violating prohibition. So sort of taboo, like breaking the rules. And so that's something that's really erotic for a lot of people, is something that feels maybe politically incorrect, or it feels taboo, it feels naughty in some way. So we'll often, if a client can kind of identify that that's part of their erotic template, is they're turned on by stuff that's taboo, then we can help them sort of explore in of sexual health, what are ways that they can explore that theme and with behaviors that still align with their values. So maybe they've been exploring with things that are taboo that aren't actually working for them, and they want to set some boundaries around those behaviors, but can we pull out that theme and find behaviors that are acceptable for them to still explore? So sometimes it's like one of the hardest things is if you're in a monogamous, long-term relationship with someone, it can be how can you incorporate the theme of taboo in your partnered sex life, right? That can be sometimes challenging for couples to figure out. And so we just get creative and we help people, bring ideas to their partner of what they think would be pleasurable, and get, start good collaborative conversations with their partner of how can we explore this together.
Right. I think that what's helpful to me when I consider sexual fantasies is it's not about the acting out of the fantasy, like Carly said. The question is, what does this fantasy make you feel like, right? It's always about how we are experiencing ourselves as we are fantasizing about whatever it is that we're fantasizing about. So if we can create room for that conversation, we can start helping client to get in touch with their authenticity and what is it that they are seeking to experience versus the specifics of whatever act that they are imagining in any particular day, right? So perhaps, Rachel, to go back to your example, maybe there's something about this vulnerability and being still empowered with serving of appetizers, yet very exposed and in a place of safety with a whole bunch of men and representative of this, heteronormative, maybe masculinity concept of this dudes watching football, right? Something about it that I would love to have this conversation. What about it is empowering? What about it? Like, what does your body feel like? Or maybe for some people, fantasy of being dominated or being, treated in a certain way that they would actually not want to be treated in real life. I had a client who had enormous amounts of shame around fantasy of women cutting off male genitals as an act of empowerment. And as a male, he felt that something was incredibly wrong with him. He came in with such an enormous amount of embarrassment, and it took us a really long time to get to a point where he felt comfortable to share that. And it was a beautiful experience in therapy, and the way we worked through it was incredibly gratifying for therapeutically, clinically, right? Because the shift that he experienced was very powerful. To understand himself, the shift was in understanding himself and actually disengaging, like the part of him that felt so embarrassed and so ashamed, relief. It's very powerful.
That example that you gave, Rachel, made me think of that's like the switch in the Barbie movie where it became like Ken Land.
Totally.
And it also made me think of going back to that from a woman perspective, that expanded paper that was written, right, looking at how we look at OSBD under the patriarchal lens, engaging with women in general and how that needs to be explored more, because so many, and this is like a, you know, a DSM thing, so many things are tested on white men.
Yes.
Kind of like eating disorders are typically, and even for trans, non-binary folks, queer and trans people of color in general, thinking about what that intersection looks like. That's what that's really what's like ringing in my brain. I took some sexuality classes and intimate partner violence classes, and always distinguishing, understanding how they're separate, but where they intersect in the consent part. So I love the 6 principles.
Cool.
Awesome.
Yeah. Mhm. Yeah, I'm glad that that resonated with you.
And
I
those,
Oh, sorry.
I was gonna say the 6 principles are applicable across the board, right? They're not only applicable for clients struggling with out of control sexual behavior, they are applicable. I use it in my couples work all the time, as much as I use it in my individuals work.
Mhm.
I have a question about, it's kind of an undefined question, but I'm just thinking it through my caseload and
Mhm.
thinking about different clients and, you know, where this feels applicable in my work.
Yeah.
And I have a client who he's a cisgender, almost 60-year-old white male. And this is not the primary thing in his life, but he has some concerns about solo sex and some, you know, like he has some self-soothing, I think, like speaking to the clinical area of self-regulation. I think that that's serving, as you framed it, I was like, oh, I think that's where this is happening.
Yeah.
But he's really seems very resistant to talking more about it. And when I kind of ask him about it, it feels very, I don't know if tender's the word, but I just feel a lot of like protection.
Yeah.
And I'm curious, I think it could be a really rich area for us to explore. When I've asked him about it, I sense there's a lot there, but I don't know. I guess I wonder how you might start with something like that.
Yeah, great question. Yes, sometimes just talking about these things can bring up so much shame for clients, and you want to kind of think about going slow to increase their tolerance with that, right? Because sometimes if it's like too much too fast, they shut down, and then that's not helpful, right? So sometimes I'll start with talking about it. What do you think it would be like to talk about this more? Oh, I would be so embarrassed to talk about this more. Yeah, okay, you'd be really embarrassed. What do you think? What do you think might be the thoughts going through your head if we talked about this more? What do you think it would feel like in your body? You know, like just so really going through, not even getting into the details yet, right? But just talking about it. Would there be any things that would feel totally off limits for us to talk about? Okay, so that would, you feel like you could talk about when you had solo sex, but you wouldn't want to share any of the details. Okay, yeah. So, you know, just you're doing a lot of that motivational interviewing techniques of like reflecting back, and kind of meeting them where they're at in terms of their readiness. So that's where I would start, would just be like, getting a sense of how he might expect to feel if they were to get further into that process and share more details, and then clients end up kind of moving towards that place of once they've processed their feelings about what it would be like to talk about it, then they kind of get closer to being ready to actually talk about it.
Yeah, in emotionally focused therapy, what Carly here is talking about is called slicing it thinner. So when you slice something thinner, right, you kind of, you stay in with it. But if something is difficult to talk about, let's talk how it's difficult to talk about it. Let's just slice it a little thinner and make it less threatening. Because when, again, attachment, right, we go into attachment distress when we perceive that we may be rejected or judged, and typically our own parts that are carrying that weight of projecting outward, right? If you have immense shame around something, you just automatically assume someone else is going to judge you, right? So then if you're making space for that, you say, I notice there is discomfort. I always call out what I see, right? I just say what's present in the room. I notice that when I ask you this question, you seem to tense up and you look away. and then you make a pause that's a bit longer than usual. And so it makes me wonder, what happens for you in that moment, right? Like what's going on for you in your body, and what you might be telling yourself, oh no, she's gonna ask me about this. And okay, so I'm learning. Thank you for teaching me about you. You're telling me this is uncomfortable. Can we talk a bit about that? What is it like to have this conversation? Many of these men, they have not had these conversations with another human being like that. Like this is brand new. Just because we are comfortable doesn't mean they are, right? So we have to meet them where they are.
Yeah.
Yes, I think I went a little too fast with it at first, assuming that comfort that wasn't there, because he sort of shows up in this way that's pretty confident, and then
And you learn something, and there you are, freaking awesome. You learned something, so now you got something to work
And it's
with.
so great that you're asking, because if a client's feeling a lot of shame about it, they're going to be avoidant. They're not going to want to talk about it because they're not going to want to feel that shame, and we don't want to collude with their avoidance by not asking about it, right? We don't want to model that avoidance for them. So it's great that you're asking those questions for sure.
That's funny that you say that too, because that's what he said the next session. He was like, I really feel, how did he say it? Something like, I was really upset. No, he didn't say that. He just said he noticed how easily I talked about it, and it really activated him. Like how easily I said, like, what have you considered an open marriage? Like these different pieces. He and his wife have not engaged into sexual intimacy in like 12 or 14 years, something like that. And so that's a need for him. So as I've been exploring it with him here and there, I'm noticing like that avoidance and
yeah.
I also love how Carly and Nika, you guys both just did what it sounds like you're talking about doing, which is this like, how wonderful you're sharing, just that encouragement of the honesty that you talked about. It's so positive.
Yeah.
Yeah, it's so positive. It's wonderful.
Yeah, that's what we're here for, right? All of us show up with a lot of care for our clients. And we always, we pick to do this work for a reason. You always get to remember who you are and why you're doing this.
So another question I had into kind of what a treatment plan looks like, or what the assessment does for folks is, especially when it comes to like relating this, because I was thinking about your case, I think case number 2 or 3, I can't remember, in relating it to childhood. Does psychodynamic and psychosocial come up a lot with where they may have had some triggers or things? So like we're talking about shame and guilt and things like that. Does that come up, and does the assessment address any of those stages that folks may be in, or have had some difficulty or life difficulty around those certain stages?
Yeah, certainly assessment does incorporate review of attachment history, of sexual history. It definitely acquires that information and organizes it, and helps client kind of consider possible connections, right? So all of these pieces float out there for the client, but they most likely have never had an opportunity to put it together in that context and relate it to why that might present certain way in their behaviors, and how that could all be influencing each other, right? So assessment is not treatment though. So there is a big difference there. We don't engage in treatment, and clients will try every time, I swear. They will try to pull us into treatment, right?
During the assessment phase,
But they will try to kind of like go deeper. And I have struggled as a clinician to not go there, because again, I'm so attachment focused, and it's just like who I am to my core. And so I just want to lean in with them, right? And I just want to do the thing. And I remember Mark just be like, you gotta stick to this. You need to keep yourself self-regulate, right? So we need to be very specific about what assessment is for. But yes, by the time they're done with the assessment, they're like, oh, well, of course, makes sense, because I have experience all of these things in my life. There could be a reason why I'm so distressed, and how come I am not able to self-regulate better. No one ever taught me. Of course, in my family system, that was never demonstrated. I was never held in that way. Right. How would I know? So now they know what to do.
And I certainly think I'm personally not trained as a psychodynamic therapist, but I know some psychodynamic therapists who do OCSB work, and it seems to integrate really well with this model. So they incorporate that as part of their treatment.
Yeah, I use some psychodynamic interventions, but for me, attachment focused therapy and internal family systems is my primary ways of working with clients, with motivational interviewing, but psychodynamic principles to help.
Thank you.
I'm aware of time and I want to honor your guys' time. Any last things you want to share before we?
I don't think so. Just we're open
We're
to, yeah, we're here. We're, open to if you ever have questions or if you have a client who you think might benefit from getting an assessment or this type of treatment, you're always welcome to reach out.
Or even if you just wanted to ask a quick question and do like a 10-minute phone call, that I'm
Mhm.
totally open to that.
Mhm.
Amazing. Well, this has been incredible, and I'm so glad we have you guys as a resource. We have you guys. I will. I wrote down the books you mentioned, so we'll grab those for. It was the Jack Moran book, and then also the OCSB treatment guide. We can grab those for the office, and then we have your guys, Nika and Carly. We have your information on an internal referral sheet with kind of the details of how you work and who you work with. So folks have your contact info. The whole team does. I'll also include it in the training notes for this particular recording. So if you guys are wanting that, it'll be on the YouTube channel too. But thank you so much for, I mean, gosh, your years of study and then, putting together, I know what's a complex topic, summarizing it for us. I know it's a lot of work to put that together. So
Thanks for having us. Thanks for letting us come talk about it.
Yes, thank you all for showing up and making time for this. We were all busy and just you being here means so much.
Totally.
And all of you who are going to be watching the recorded version.
Yes,
So thank you for
totally.
taking time to do that.
No, I think that all of us, work with clients where this is incredibly applicable, even if it's not as direct, it applies to anyone, aligning with our sexual values and the 6 principles. So thank you so much. What a rich conversation.
Thank you.
Well, have a wonderful week,
so much,
everyone.
guys.
I'll stop the recording.